that it is resulting from a systemic disorder. Categorizing the patient by clinical symptoms as having mild disease, moderate or severe disease can also help steer the therapy. Now, while we are doing physical examination of these patients, we can focus on certain physical examination findings like scoliosis on examination can easily give you a clue. Paravertebral muscle spasm can be picked up on examination. Leg length discrepancies can be seen. Point tenderness is usually specific either for a compression fracture, infection, or a malignancy. Limited spinal motion, although a common finding with patients with backache, it cannot help you diagnose specifically if this is inflammatory or mechanical, because both can cause limited lumbar flexion. A straight leg raising test is usually positive in patients who are having severe pain, and that's not very helpful in making a diagnosis. Neurological examination about the nerve roots 3-4, L4, 5 or L5, S1 can help you establish if the pain is coming from the nerve root irritation or is it radicular pain. Now, there are some indications for early diagnostic testing. Every patient coming in with a backache does not necessarily need even a simple plain X-ray. Most of the cases, it can be diagnosed easily on examination. I mean, you can make a decision if the patient needs an extensive workup or not. There are certain indications for workup like spinal fractures if you are suspecting that, infection or malignancy if there are symptoms of cauda equina syndrome, or a seronegative spondyloarthropathy is in the list of differential. Laboratory studies have a limited role in making a diagnosis in certain patients. Mostly, you can identify the systemic causes by getting some routine blood work done like CBC, ESR, CRP, and creatinine levels. Diagnostic imaging. Unfortunately, although we keep complaining about the limited resources in our country, but every patient who ever complains of backache gets an X-ray, at least an X-ray done even on the very first visit to a general physician, to an orthopedic surgeon, or anywhere. And most of these patients, if they are not responding after 2-3 visits, get an MR done. And now there is a problem with MR, like looking at your hands with a microscope. You'll be horrified to see billions of germs. So if you get an MR in anybody more than 60 years of age, there are certain degenerative changes. There are some little bumps on the spine and the vertebral bodies. There are some indentations on the spinal canal, narrowing of the spinal foramina. And these findings are written on the radiologist's report, and then the patients keep on carrying these MRs and abnormal reports to everywhere and say that there is an abnormality and probably the back pain is resulting from that abnormality. But actually it's not true. Most of these MR findings do not have anything to do with the clinical symptomatology of the patient. So imaging actually cannot determine the cause of the patient's symptom in most of the cases. Abnormalities can be visualized, but usually there is no conclusive evidence, plus there is a risk of radiation exposure. However, imaging can be used to diagnose some major diseases when it is indicated, definitely. When should we get the imaging or further investigation done? There are certain red flags in any patient's history and physical exam, which include fever, trauma, history of malignancy, immunosuppression, unexpected weight loss, failure to improve, the back pain is not improving despite appropriate therapy. That could be an indication. If the patient is elderly or too young, history of alcohol or drug abuse, or history of steroid use if you are suspecting osteoporosis. Plain film can be done and it can show evidence of infection, fracture, or malignancy, spondylolisthesis, degenerative changes, disc space narrowing, and evidence of prior surgery can be seen on the plain film. You can evaluate about 10 points in soft tissues and bony structures, including the intervertebral disc, spinal canal, intervertebral foramen, vertebral bodies, superior facet, inferior facet, transverse processes, lamina, spinal processes. Now there is one thing, there is often a finding reported on the X-ray, that is fracture of the pars interarticularis. And I have talked to various radiologists and I couldn't find the exact significance of this finding if this is related to the symptoms. Most of the patients having this fracture reported in the X-ray of the pars interarticularis, if they never had a trauma or any history of fall or anything like that, usually that fracture is asymptomatic and is not the reason of pain in that particular patient. MR can be done. It's a good technique for soft tissue imaging and looking for the nerve if there is a suspicion of radicular pain. Films can be abnormal, but radiculopathy may or may not be related to the MR findings. You can find a bulge, degeneration, facial protrusion, sequestration, etc. Now, in chronic back pain patients, when we look at the outcome measures, that is back-specific function, severity of pain, and the patient's global satisfaction, these are the tools used by various research purposes when they are conducting a study. They're in their particular field, in their occupation, what to do and how to prevent recurrence or relapses of these backache. Medications do have a role, usually in acute backache, but in chronic backache, you don't want the patients to be committed to a medicine, especially if it's a narcotic analgesic, for a very long time. You can use various groups, including non-steroidal, muscle relaxants, analgesics, antidepressants, anticonvulsants, and miscellaneous groups. When you are using NSAIDs, acute exacerbations can be treated with NSAIDs with shorter half-life. Those with longer half-life can be used to have a sustained effect. COX-2 inhibitors, they are less toxic, especially on the GI tract, but the efficacy is almost the same. There's a big list of muscle relaxants available. What we have available here in Pakistan, we don't have cyclobenzapine. Orphanadine citrate is available. We don't have metabolone, fluoroxazone. We got trizanidine, atracinium, and thiocolchicite muscarel is available. Analgesics, we have to choose between non-narcotic and narcotic analgesics. Non-narcotic analgesics like acetaminophen and tramadol are effective and they are not addictive. Narcotic analgesics, we have many available, but we should try to avoid narcotic analgesics because of the risk of dependency. Antidepressants do have a role. Low-dose antidepressants like amitriptyline, nortriptyline can be used. Duloxetine could be helpful in patients who have psychosomatic component to the pain. Then anticonvulsants like carbamazepine, gabapentin, and pregabalin can be used. Chronic low back pain therapy, you can use other modalities like massage, prolotherapy, radiofrequency denervation of small nerves to the facet joints. There are some studies showing that if the facet joint is suspected to be the cause of pain, you can use radiofrequency denervation, but it's not a validated treatment. Spinal cord stimulators are available, which cause stimulation of the tissues around it. For prolotherapy, the idea is that probably back pain is resulting from ligamental weakening, so injection of sclerosing agent into the ligaments can cause fibrosis, thickening and tightening of the ligaments, and that can help relieve pain by increasing the strength of those ligaments. Similarly, intradiscal electrothermal annuloplasty is being studied, but it's not a proven therapy. And balloon kyphoplasty is also studied, but we don't have any definite results about this.